I'm really excited about Dr. Berube and how we came together, which I'll explain, but just a little history. You know, for eons, we died young of infectious disease. And then Dr. Ewald, in his book, Paul Ewald, E-W-A-L-D, talked about the book called Plague Time, how, you know, back in the day, we died of infectious diseases, and today we die of cardiovascular disease, cancer, Alzheimer's, so on and so forth. But what he shows in his book is that really, if you titrate to what is at the root of these diseases, it's chronic infection that's largely ignored, even among functional medicine, alternative medicine practitioners, but 100% by standard of care doctors. But what I've seen in my work is there's no question slight elevation in white blood cell counts, and white blood cells respond to infection, is most greatly tied to people that have some type of oral problem. So when you look at the preponderance of infectious diseases that affect our health today, I would say that periodontal infections and gingivitis are at the top of the list, and second place is way far behind us. Benjamin Rush, founding father and medical doctor, signed the Declaration of Independence in 1806, said, "I am just yet another humble clinician that showed the relationship between removing an infected tooth and the improvement in that patient's overall health." And then came Charles Mayo, presenting to the American Dental Society conference in Chicago in 1913, who said, the next great wave of prevention, what he really means is improvement in health, will be delivered through dentists. And today, if you go to Mayo Clinic, I think you'd be very lucky to have your primary care doctor ask you about the health of your mouth. And so that's why we have 60% of our of adult Americans have at least one chronic condition. But, you know, 33% of us are obese. There's another 33% that are overweight. This is intimately connected to oral health and inflammation. And so understanding that when you go to a dentist, it's the Wild West out there, because they're the only profession that's kind of saving a dead tissue. If you have a gangrenous toe and you go to a podiatrist, if they don't get Dr. Harshfield to intervene and Dr. Carter to intervene to try to get blood flow to that tissue, they're going to amputate it. But dentist's mission is to save that tooth. And that may not be the right way to go. The reason why Dr. Berube is so important is because there are so many facets to oral health. And if your oral health isn't optimal, what are your options? And a lot of these options can be very expensive. They can affect structure. They can affect, how you feel about yourself, all different kinds of things. So I always tell Dr. Berube, I always tell people that when I have a consult and see something with an issue with their white blood cell counts and oral, that Dr. Berube is your insurance policy because you may not be able to go see her outside of Dallas, but you need to go informed to your dentist or periodontist or endodontist or whatever, oral surgeon, with as much information as you can to get the job done right, not just to focus on the mouth, but to focus on your total whole body health. And with that, Dr. Berube, take it away. We're waiting with bated breath to hear what you have to say.
Well, first, I want to say thank you to Dr. Lewis for inviting me to work with you. It's an honor. I'm actually really nervous tonight because I know your clients are all very well versed and intelligent, probably more so than just like you said, many of the dentists out there, because we have the internet now and we can research for ourselves. But what I want to talk about tonight, well, first let me talk about, I'm a functional periodontist, which is what Dr. Lewis has named me, and I'm actually pretty excited about that. I am a periodontist, which is a specialist that works on the gums. So it's mainly a surgical specialty. However, we work with diagnosing and treating gum disease. That's one of the things that we work with. And one of the things that I found that I feel that my training didn't prepare me for was all of these cases that never got better. And then you wonder, why are they not getting better? So hence, based on my personal life, that's where I've gotten into functional medicine. I've become certified in functional medicine. I read everything I can get my hands on. And I realized that, what we were taught, and that was 20 years ago, was just like we talk about in medicine. It's a very small box, and there's so much else that we can learn. So I learn every time I speak to one of Dr. Lewis's clients. They'll talk to me about a specific oral hygiene product that I've never heard of. I don't think I know everything, but I hope that I can explain a little bit about this oral DNA test that Dr. Lewis recommends. And hopefully people can watch this video if they do get a test and have most of their questions answered. And then, of course, love to have consultations, love to chat. But hopefully with those consultations, it will be, you uploading your x-rays and me giving maybe a second opinion and explain to you the processes and some of the choices that you have to moving forward with your dental care. And if you have any questions, if you want to write them down, we can talk about them later. That would be great. So basically tonight, I'm going to discuss oral systemic conditions. I'm going to go through some studies, some of the classic literature that were decades ago, but are still relevant now. And Dr. Lewis, you were absolutely right in saying that I've been in practice for 20 years, and I have never, I can say never, gotten a referral from an MD to check their client's health status or oral health status. I am now getting referrals from naturopaths and functional medicine docs a little bit more, but I have cardiologists all around me in my complex. And when I first got out of residency, I was gung ho and I went around to everybody, and they just don't do so. So it's amazing that Dr. Lewis understands this link.
Well, I was trained by the best, and Louise knows Dr. Trump very well as an ophthalmologist, but 30 years ago, he was telling people that had glaucoma that they needed to take care of their root canals. And a little sidebar, so he educated me 20 years ago, and a little sidebar, when you first came on and agreed to do consults with some of our folks, I sat in on the first 2 consults you did, and I just want people to know, even though I know, Patty, you want to kind of like make sure people come to you with the right information and get the right value. But the level of information you provided in those consults was so superior to what I could do, that it's not a continuum. It's a huge leap to have the consult with you.
Well, thank you.
Yeah.
I didn't know you were listening to those calls, but
no, just the first 2. Just the first 2.
That's okay. It's okay. Another thing we'll talk about is what the oral DNA test is and interpreting it, because I think a lot of people that get these test results, they look and see the results, and their first reaction is to kind of freak out about it. So I want to empower you to know what you're looking at, and then empower you to know how to diagnose gum disease. I would love to say that if you've been going to a dentist every 6 months forever, that they would have diagnosed gum disease, but unfortunately, that's just not the case. There's overdiagnosis, there's underdiagnosis, and there's everywhere in between. So I want to be able to give you the tools to know what to look for at your dental visits. Strategies for treatment, I'm not going to talk too much about in the dental office. I'm going to just talk about things that you can do at home mostly, and then just a couple clinical cases. So the first study, I know you can't read it, but I'll just talk about it a little bit. Again, this is classic literature. This is the stuff that we learned about in residency, and we sat in a room and we discussed every week. But it's been out for a long time. This specific study was 1989, and it's by Matilla. And he basically observed that his acute heart attack patients all seemed to have bad teeth and gums. So he started to investigate that. Another article that he wrote, he basically found the same thing. He confirmed his findings in another study. And you have Dr. De Stefano that came out and said, no, there's no relationship. And so he went out and used one of those NHANES data sets. And what he noticed was that individuals with periodontal disease were 24% more likely to have cardiovascular disease. Then you have Beck, who also looked at periodontitis in particular. And after looking at a large database and adjusting for other cardiovascular risk factors, they found an odds ratio to be 1.9 for fatal coronary heart and 2.8 for stroke, which is pretty considerable. So these are decades ago that they started looking at this. Do all of these studies say that oral disease is related to systemic disease? No. But as time has gone on, we've seen that there's actually causation, and I'll talk to you about that. This is a USA Today report, and that was in 1998. So I was in dental school when this article came out. This was on the cover. This is kind of a big deal, and this is when people started to take notice. If you read a USA Today, this isn't a new thing. And when it starts to come out in the lay press, then there's some teeth to it. Well, there should be. This Time magazine, this was back in the day when they had 180 million plus readers. I don't know about now how many readers they have, but they talked about the secret killer. And this was a 7-page article, not too shabby. I mean, they're talking about the inflammatory component with Alzheimer's disease and atherosclerosis and obesity. And in this little, 7-page article, periodontal disease got 2 lines. So that's not too bad. But it's talking about how the oral cavity is a source of chronic inflammation. So this idea of what's going on in our mouth causing inflammation it's not a new concept. So here's a study, and I'm not going to go through studies all night because I'm sure that bores many people.
Not my group. Not my group.
So this is a really great, simple study, and this isn't funded by anybody, so it's actually a pretty good one. Basically, some people had periodontitis and some people did not. So they gave the patients a stick of chewing gum, and they're to chew it 50 times per side. Then they drew blood, and what they're looking for in the blood was endotoxin, which comes from gram-negative bacteria, which is very common to gum disease. So they drew blood again 5 to 10 minutes after. Okay, so periodontally healthy, meaning they don't have gum disease, they showed 12% of those patients that are periodontally healthy have endotoxin, which is the LPS. I'm sure you've talked about that. So there is low levels, but people that with gum disease had 40% higher than, basically had 40%. So you're talking about a 5% higher amount of that endotoxin in their blood just from chewing gum. So this is, I think, a huge study to hang our hats on. Here's another study. This I regularly quote to my patients because this is never discussed at their MD's office. And I can tell you with my patient population, I have 2 sets of patients, but most of my patients are on many medications and they're being treated for past heart attacks and et cetera, and they don't know why it's happening. And so when I talk about this study, they basically looked at atheromas, and Dr. Lewis, I'm sure, knows all about this. They look at items like chlamydia and cytomegalovirus. But essentially, they found the same bacteria in the atheromas that cause heart attack. It's the bacteria from our mouth, essentially. So it's again, this has been out there for a long time. And let me just see if I forgot anything in my notes. But what they looked at in this particular study was the carotid and the epicardial arteries. They did it. They used DNA techniques. They used culture techniques, and basically they saw live periodontal pathogens from our mouth in these atheromas. So I quote that a bit. This is another study that talks about elevation of systemic markers, cardiovascular disease. So CRP, C-reactive protein. I know Dr. Lewis checks routinely for high sensitivity C-reactive protein. IL-6, which is a component of that oral DNA test. It's basically associated with a higher level of angina and cardiovascular disease. And then also they looked at polymorphonucleus, anyway, PMNs or neutrophils. So what they found is these elevated inflammatory factors may increase inflammatory activity in atherosclerotic lesions. So what we're finding is basically, what's caused in the mouth is causing these inflammatory in the body. Another study, I didn't think I put this many in here, but again, talking about C-reactive protein. So C-reactive protein here increases, these levels increase in periodontitis patients. So it's parallel to the severity of their disease after adjusting for things like age and smoking and body mass index, triglycerides, and cholesterol. So again, it's very rare that I even see, as I look at people's blood tests, it's very rare that MDs even look at CRP levels, but it's absolutely relevant to what we do. And it's talking about, they talk about subgingival flora, but elevated CRP levels are associated with that infection that come from those microorganisms that we find underneath the gum line, which is often associated with gum disease. So some of those, I'm not going to get too far into the bacteria. That's a whole other webinar, but Porphyromonas gingivalis is a big one, PG, Prevotella intermedia, Campylobacter recta, and Bacteroides furcites. Again, I'm not going to go too far into that, but Zakransky's studies on looking at the red complex is one of the bigger classic literature studies or authors that we quote. And if you look at this red complex, hold on, I have a little laser pointer. Okay. This is the red complex. So these are determined to be the most severe or that cause the most severe gum disease. So they talk about it being the most pathogenic grouping. And but there's hundreds of bacteria in our mouth. So I'm not going to go through that too much. So as Dr. Lewis talks about all the time, we're not just looking at bacteria in the mouth, but also inflammation. So periodontal disease is inflammatory, it's infectious, it's immune. There's all of these different factors that are involved in it. But when you're talking about all of these disease processes, and this isn't an exhaustive list, it's all inflammation. So it's all causing or is caused by inflammation. Well, it's causing inflammation. So here we go. And we're talking about where does the oral DNA test come in? And I don't know if you guys are familiar with the Balin Doneen book called Beat the Heart Attack Gene. I read that several years ago. And to me, it was, I think, a great bridge between kind of conventional allopathic medicine and more naturopathic or holistic medicine. And because they talked about how important it was to their practice to diagnose gum disease, because they feel that was the cause of heart attacks and stroke. So they talk about it as being a medical problem with a dental solution. And they are the first ones, they put out this study, and they were the first ones to establish, and I say causation, of periodontal pathogens to atherosclerosis. And it's actually a really interesting paper if you can get your hands on it, if you haven't read it already. And it talks about how gum disease affects, they call it the triad, and there's different, there's a sequence of events that occurs for gum disease to affect atherosclerosis. So in that, actually, I'm going to go back before I get there.
Patty, I'll mention one other group. So Thomas Rau of the Paracelsus Clinic in Switzerland had a team of 10 or 11 practitioners, 3 of which were dentists. And he had years ago, I met him, he had a world famous clinic. And I also met Brad and Amy, and they met Dr. Tremp, and we explained, it's definitely not the gene. I'm not sure when they wrote that paper, but, Dr. Tremp introduced them to things like chlamydia pneumonia, rickettsial diseases, and other ones as well at the time. So we have a history.
Oh, good. So the thing that I found important, and I'm going to go backwards a little bit. With Bale and Doneen, I'll go back to Bale and Doneen's book. What I found interesting, and I thought it was very true, was she'd have a patient that had high inflammatory markers in their body. And she'd say, have you been to the dentist lately? And they go, well, yes, I've been to the dentist. I go to the dentist all the time. And she says, okay, well, have you ever been diagnosed with gum disease? And they say, no, I have not. And she says, well, there's something going on. I want you to go to one of my dentists. And then they go to one of her dentists that she's used to working with, and they diagnose gum disease. And then they do an oral DNA test, and it's an objective finding of information that can be used anywhere. So, in her or his, I'm not sure, words in the book, they didn't understand how you could have different material coming out or different diagnoses coming out of different dental offices. Because in the medical world, you take a blood test is a blood test is a blood test. You get the same results. In dentistry, a lot of it is very subjective. It's based on what you're looking at, if you're looking at it, and how trained you are to look at it. And, like I said, there just isn't always that diagnosis happening.
That's a brilliant comment that people really need to stay in tune with, because I experienced the exact same thing that Bale and Doneen experienced. I see slight elevation in white blood cell counts. I look at everything. We've run chlamydia pneumonia. We've run other things. I'm looking at, mild bleeding gums. And some people are very hard to convince that it can be something in the mouth. And I describe it as, your mouth is like an iceberg. And the dentists do a very poor job of figuring out what's going on below the gum line. Mm-hmm. An X-ray is a very inadequate tool.
It's what we've been taught. And there's dental school, then there's periodontal residency. And so there's a lot of dentists that don't know a lot about gum disease just because they've never been taught. And then there's a lot of differing information out there. You go to CE courses, everybody has a different way. And that's why I just want to explain to you what to look for, so that when you're at the dentist, whatever dentist it is, it can be biologic or it can be a regular dentist. I would love to say every biologic dentist is the same, but they're not. It's just like every MD, everybody's different. So in their training and what they focus on. So I want to make sure that your clients know what to look for when they are at the dentist. So this is where the oral DNA labs testing comes in. It's an objective test. So, getting our blood drawn, and in this case, it's a salivary test. You're going to find just useful information for you. I have patients in my practice. I don't use it on every single person because they have a lot of work to get done, and they're not going to do it. But for me in my practice, it's different than an MD's office. For me, they already know they have gum disease when they're walking in the door. So, and I'm there to diagnose it. But those patients that have had heart attacks and stroke before, and they say, my MD doesn't know why. I really want to get an oral DNA lab test. I also run it on people that have just really severe disease, or they're really young, a lot of bleeding, a lot of local factors. It's just really great information to see before and after. So the tests that I'm going to talk about today, they have several, but the two tests are Alert2, which is the 11 pathogens, and then that IL-6 that we were talking about, which is a gene marker, and then the myoperiopath, which is just the 11 pathogens without the IL-6. So this is an example of what you'll get when you get your report. Sometimes I think it just depends on how Dr. Lewis marks it, but sometimes they'll have these thresholds on here, which is these horizontal bars. And it was actually you that kind of went through it with me and discussed that these thresholds discuss basically moderate to severe disease. So anything below this threshold is considered to be mild, and anything above is considered moderate to severe. And
I've had oral DNA labs take off those bars because I don't want people to think if they're below those bars, they're good.
Right.
And so we no longer get the report with the bars.
Okay. So I kind of guesstimate if I'm, on a consult with your clients, I guesstimate kind of if I think it's over a threshold. And the only reason for me is, and I'll show you a couple cases of what I mean, is for when I see clinically gum disease, usually all of these are elevated. Most of them are elevated beyond this threshold. And then people that don't have gum disease, and again, this is a generalization, but they have a few, right? It's not every color of the rainbow here. So, in this Alert2 report, it'll also give you the IL-6 marker. So what this means is, if you're high risk category and you're getting treated for gum disease, and I extrapolate that it might be, and with other things too, it's harder for the body to heal from it because you have that gene marker. So when I have people that I know have severe gum disease and they're just not getting better as easily, a lot of times it's this IL-6 is high. And you don't have to obviously just get this one time if you want to know for educational purposes. So here we're talking about, and this is more of what you'll end up getting of what it will look like. And I'm not going to go through all this interpretation of results, and the back side of this will go through what each bacterium is linked to, i.e. heart attack, diabetes, cancer, etc. That you can read on the back, and they're actually going to, I believe, change this a little bit. I don't love how they report how the bacteria affects. It just doesn't seem easy to read to me. But in this scenario here, when you're talking about treatment considerations, and this is an important thing to look at when you have your report, is you've got to know if you have gum disease or not. And that's going to dictate what type of treatment considerations you can consider. Okay. So I'm going to go through that in a minute, but I'm going to skip to this part here. The first part is scaling and root planing, and that's only if you have gum disease. And I'll explain that a little bit later. Systemic antibiotics. So that's where these thresholds come into play. Anytime there's bacteria over the threshold, they're going to give you the antibiotic that they feel will help. Well, not that they feel, but that will work with that specific strain of bacteria. So if you've got nothing over the threshold, they don't put any systemic antibiotic recommendations on here. So systemic antibiotics, again, it's, based on sensitivity to the bacteria that you have. I don't always recommend this for patients. This is something that is very specific to each person, because we know that antibiotics will affect our gut bacteria. So if you've got some bacteria, but not much, and you don't have gum disease, I personally wouldn't recommend antibiotics. For me, when I use antibiotics, are patients that have so many chronic diseases, history of heart attacks, just inflammation all, everywhere. And I know when we get in there to do a deep cleaning, which is that scaling and root planing, we know there's going to be a lot of bacteria that's going into their bloodstream. So that's when I recommend antibiotics. As of right now, most of the clients that I've done consult with, they haven't had the need, in my opinion. But again, that's a discussion to have with Dr. Lewis or your dentist, which you can bring these results to. So here they'll talk about local antibiotics and chemical hygiene. Personally, I don't recommend any of those. I don't even carry any of these in my office. They're basic. It's a moneymaker, in my opinion. Sorry, I'm just going to say it. I just have never used it. I think in certain situations they could work. It's basically antibiotic that you can just locally put into a pocket. But again, you need to have gum disease for that. Pocket or field decontamination they're talking about laser decontamination. Again, that's going to happen if you have gum disease. And if you need scaling and root planing, some hygienists are trained with that. I personally don't have my hygienist doing that in my office. I do that when I have to get under the hood a little bit more, and I use my lasers for decontamination. But that's not a bad thing. It just costs a lot more when they do it. Chemical and trying to read this small writing here. Chemical and gaseous antiseptics. I shouldn't say never. I don't recommend chlorhexidine in 99.9% of cases. I'm sure I don't know if you're familiar with chlorhexidine at all. I do it for very specific situations, but chlorhexidine or Peridex can cause an increase in bacterial resistance, and it affects how you taste. I just don't use it. It's just not my favorite thing. They do iodine rinses, which is fine. And then they also talk about ozone, which, again, that could be another webinar. That's fantastic adjunct to treatment. The next treatment is probiotics and prebiotics. This is something that I regularly recommend to patients with or without gum disease. There are oral probiotics. The one that I use is by Life Extension. It's called Fluorocist. I change it out sometimes. But it seems to be the most cost effective. Some of these out there are very expensive. And for a bottle, we don't want to spend $80 on one bottle for a month. But those are just lozenges with oral bacteria that we put under our tongue. So it's trying to reseed the better bacteria over the bad pathogenic bacteria. And then periodontal surgery, that's only if you come see me. So that is for severe cases. And unfortunately, there's still a lot of offices, biologic and regular, that just don't refer to a periodontist. They're trying to kind of keep everything in-house. And there are indications for surgical treatment. Again, that's just kind of beyond the webinar at this point. It's not all bad. So how do you know if you have active gum disease? That's the biggest issue here. Most of the clients that I've talked to in these consults, they kind of know. They know because they know exactly what I'm talking about with the probing depths, which I'm going to get into. But some say, oh, wow, I've never had that done, or I don't remember them doing this. So basically, you can't just look at the gums and know. That's something many people still haven't learned in the dental world. Unfortunately, you can look at somebody and yes, if it's bad, if it's bright red and it's bleeding, but there are times when it looks okay and they've got gum disease. The only way to know is by measuring, and you use a little measuring tool that I'll show you, is taking the oral DNA test to diagnosis. No, technically it's not. So that's why you have this oral DNA test. Use it in conjunction with the findings that and then can you rely on your dentist or dental hygienist to accurately diagnose gum disease? Maybe. And that's where you come in, where you say, hey, did you take my probing depths today? And you'll know exactly, they'll go, oh, let me show you. So I want to teach you how to, what questions to ask and what to look for. So in our office, we always take radiographs, period, end of story. I know people don't like taking radiographs because of radiation. However, I can't diagnose gum disease without a full mouth series of radiographs. And I'll show you an example of one later. That's 18 little x-rays. We do that only about once every 3 years, maybe more, just depending on the case. So if you've got somebody that's very severe, we might take it more often. If we have somebody that's not and that's pretty stable, we might take it less than once every 3 years. A full mouth series looks at every single tooth, and it looks above the roots and in the surrounding bone. And I'll show that to you. These probing depths that I'm talking about, which is, I've got a little picture here. Okay. It's called a probe. This is a Maryland probe. It has what's called Williams markings on it, but these are little millimeter markings on here. Okay. So these should be taken 6 points around each tooth. So, if you have, 32 teeth, there should be 3 on the front, 3 on the back for every single tooth. Okay. And then noting any bleeding and/or areas of recession. So if you look right here, based on this, I'm assuming this is 5 millimeters. This is 2 millimeters. That's fantastic. So anything 1, 2, and 3 millimeters is considered to be normal. And if you picture, let me show you. I think I have I'll show you here. Okay. So in this first slide, you see it's at 3 millimeters here. Okay. It's showing a little redness because that's gingivitis. So gingivitis is inflammation of the gums, but it's reversible. So if you clean well and do what you need to do, which we're going to talk about, this will reverse itself and this will be nice and tight. So when it's 3 millimeters or below, you picture it's nice and tight, a nice collar around the tooth. So there's no place for bacteria to hide. And when you brush, you can brush in this spot and you get everything you need to get. With gum disease, what ends up happening is that your gums, and I kind of show that this is the same thing I talk about in my practice, your gums get inflamed and they come away from the tooth. And now you've got this area that bacteria can hide. So what ends up happening, and this is just showing, mild disease. So this probe goes down a little bit more. Now you're looking at 4 millimeters, 5 millimeters, 4 millimeters or so. And you can see the ulceration in the gums here. And what ends up happening is that plaque turns into tartar buildup, and then your body just attacks itself. It's an immune reaction, and you start to lose the bone. And you can see here, bone is great. It's unaffected when you have gingivitis. When you have gum disease or periodontitis, periodont means around the tooth, you've got bone loss here. Okay. So this is mild. And then as we get deeper, we get moderate. And as we get deeper, we get severe. And you can see we're losing bone, we're losing bone, we're losing bone. And you can imagine that over time, when you lose bone, your teeth start to wiggle, and then eventually there's no support. So you're losing the foundation to your house. I can't grow that back. When it's horizontal in nature like this, I can't grow that back. When it's vertical in nature, I can sometimes grow that back. What's called regeneration. That's when I see people. But this is a silent disease. So a lot of people ignore this part, and then it gets to this part, and then it gets to this part. And by the time the teeth are loose, it's really hard for me to fix that. Okay. So basically, when you're talking about these measurements, I'm going to go through that again. 1 to 3 millimeters are considered to be normal. So if you don't have gum disease and they take all of those measurements, it should all be, 323, 323, 1, 2. You might have an occasional 4. That's okay. That's not cause to be concerned. You just want to know where it is so that you can clean it better. Sometimes if you've got a root canal or you've got an ill-fitting crown or restoration, or sometimes a fracture, or you're hitting the tooth hard, you can have a deeper pocket in a spot. So again, it's really, if you're generalized 3 millimeters and below, maybe a couple 4s here and there, I would not recommend scaling and root planing, which was on that oral DNA sheet. If you're getting into generalized 4 millimeters and above, and especially if there's bleeding. Now, some people don't have bleeding when they're home, but then when we measure, we're going underneath the gum line and they will have bleeding. So that's a little bit different. It doesn't mean you're failing at home. It's just if you've got these pockets, they just bleed when you measure. And somebody shouldn't be measuring hard either. But anything 4 millimeters and above, we're considering gum disease at this point. And that's what we were talking about. There's gingivitis, as we discussed before, which is completely reversible. That's when we see a little bit of bleeding, a little bit of plaque. That's a lot of times hormonal. Then you get into gum disease, which can be mild, moderate, and severe. And then you can also have localized or generalized gum disease. And there's actually a newer way to classify all this. I just still use this because it's easy. So as we were discussing before with the treatment considerations, if you're looking at this, you go, okay, I've got, you don't usually have these thresholds on here. You've got high risk, moderate risk, low risk. And each one of these, which we can provide for you, is linked to certain health conditions, but also to certain processes in our mouth. But when you're looking at this, the first thing that you want to do is to make sure that you don't have those deeper probing depths. And that can only really be done at the dentist, unless you're really good about taking measurements in your mouth, which I would not recommend. Okay. So when we're talking about, treatment, what is scaling and root planing? We can obviously see from somebody like this that there's a problem. And I wish I could say this was rare, but I'm a periodontist. I see this all day long. A lot of people will say, well, but that article said I don't have to floss. I have a difference of opinion on that because I see this all the time. So when you're talking about mechanical debridement, or there's chemical as well, and we'll talk about that, but mechanical debridement is still the mainstay of treatment for gum disease, because it doesn't matter if you're coconut oil pulling here or you're rinsing with biocedin and dental sedin, you're doing all these things. If you don't get this stuff off professionally, you're never going to heal. It's never going to happen. So when you're here's some studies again. So when you're talking about non-surgical therapy, which is that deep cleaning, it goes by quadrants of the mouth. This is, again, only if you're 4 millimeters or above. This is where I start on most people, because you want to try to decrease the pathogens and get them to a place where they're cleaning the best that they're going to clean and be as clean as they're going to be before we move on to other things that they may need treatment on. And I mean surgery there. So when you're looking at the deep cleaning, it goes by quarters of the mouth. The insurance likes to play games and only let you do half of the mouth at a time. I fight that all the time. To me, it makes more sense to do all 4 at the same time. You get numb for it, whether I give you injections or we have a really nice topical that works very well. And we're cleaning underneath the gum line. So if you figure you have these pockets, you're cleaning what's inside the best that we can. So you can imagine if you've got a 4 millimeter pocket and some tartar, easier to clean than if you've got a 10 millimeter pocket and you've got tartar. But it's still the first treatment. And basically, there's a ton of studies that show that just even doing some scaling and root planing will decrease inflammatory markers, such as IL-6 that they looked at, C-reactive protein comes back again, and fibrinogen. I know Dr. Lewis checks your fibrinogen levels. So all of those things are important. And it's, as a periodontist, and especially as a resident, you don't want to just do scaling and root planing. But I remember one of my instructors said that is probably one of the most important procedures that you can do for their health. And I 100% understand what he means now. So it decreases the level of inflammatory markers. Everybody just got home, so sorry, they started making noise. So non-surgical therapy with the gum disease is not the final therapy for for people with severe gum disease, but it's the beginning. Okay. Here's another one that talks about aggressive periodontal therapy, which includes scaling root planing, and then that taking out hopeless teeth. And, you know, if you have teeth that are very mobile and they've lost a lot of bone around them, then we remove those because they're hopeless. They can't come back. And basically what they found is they looked at endothelial function, or basically blood flow in the brachial artery. And at 6 months, just even doing a deep cleaning improves that endothelial function. So, you know, it's not a small thing. It's a big deal. I just had a patient today that came in and he had colon cancer and he was told he needed a deep cleaning, but he didn't want to do it. And we talked about the literature of gum disease and how that affects, it has effects on colon cancer. And so, you know, it's even something as small, it doesn't seem small to a patient, but getting underneath the gum line, cleaning things out is really, really important. It also will decrease your hemoglobin A1C levels. So people that are diabetic, it's fantastic. So sometimes surgical treatment is needed. I'm not going to really get into all of that. There's a lot of different things that we can do to improve your oral health. And I think that's where a lot of Dr. Lewis's patients, your clients, have questions of, but wait, I need to get this tooth out. Now what do I do? And, you know, that's another webinar we could do. So one of the things that we can talk about, and I talk about a lot, is oral hygiene instructions. Your clients are fantastic. They teach me things. I'm going to just kind of go through an example of a protocol. There are so many out there. There's no right, there's no wrong. Not everybody fits, you know, one. What's the saying? There's more than one way to skin a cat, right? So a lot of these instructions are with Barbara Tritz. She's a registered dental hygienist, and she works with oral DNA. She teaches at a lot of the biologic dental meetings. So I've kind of merged her information and mine. One of the things that I really think is important, it's an old Ayurvedic principle, and I can never say that word, but it's very, very ancient, is scraping your tongue and coconut oil pulling. So when you wake up in the morning, you figure everything has come down and has landed in your mouth. So use a stainless steel tongue scraper, scrape your tongue. And if you can do it, use coconut oil and pull. They say 10 minutes to 30 minutes. It's fantastic if you can do it that long. You just pull it and it takes all of the bacteria from your sinuses. And my patients that coconut oil pull, my gosh, their gums are just immaculate. So I'm not as good about doing this, but I think it's just, if you can get into the habit of doing this, it's amazing. Make sure you spit it into the garbage and not into your plumbing.
What does it mean, pull?
To pull. So you put it into your mouth, and I'm going to come early. So you're literally like pulling it through, if that makes sense. I'm sure there's a YouTube video on how to do it, but you know, usually we just rinse and spit out. This is literally just taking your muscles and pulling it through, and you're doing it for, they say the minimum of 15 minutes is the best way to do it. So, and then just make sure you're spitting it out. You're not swallowing it and you're not spitting it into your plumbing. Another thing that you can, you know, we know to brush our teeth. We all know this. You can use an electric toothbrush or not. I'm probably the only dentist on the planet that doesn't recommend, you don't have to use an electric toothbrush. If it makes you more compliant, fantastic. I just use a regular toothbrush still. Use, 2 to 3 times a day, as much as you can. You want to brush into the gum line in general. If you've got recession, that's a little different. But adding baking soda, it's easy, it's cheap. It's, you have studies that say, oh, it's abrasive. Well, it's not compared to regular toothpaste. Again, I'm sure you're all very educated on what's in toothpaste. So even just adding baking soda will increase the pH in your mouth, which will, we want the acidic environment to go away. We want it to be more alkaline, and that favors the better bacteria over the pathogenic bacteria. I know baking soda tastes terrible, but it works. You can also, I keep a little tin, and I do baking soda, maybe some sea salt. So, real salt, not white salt, but real salt, and you can use that as well to brush. Once a day. So doesn't matter when. I don't know why I put morning or noon. Doesn't matter when you do it. You want to floss. And again, there's a million ways you can do things. The reason why I feel like flossing and using, and I'll talk about Oxybrush here, it's that mechanical debridement. If you've got plaque that's starting to form on your teeth, I think coconut oil pulling is not going to necessarily knock it off. So we've got to brush, we've got to get in between where the gum and the tooth are meeting. And it's just another place for bacteria to hide, and floss can get there better than a toothbrush can, or even sometimes a water pick. So that mechanical action is very important. And what you're going to use is what's called a Proxibrush. They're the little Christmas tree brushes that I now carry around with me because I have bigger spaces in my teeth. And what the Proxibrush does, if you can dip it into colloidal silver if you want to, or hydrogen peroxide a couple times a week, but you're putting it in between the bigger spaces in your teeth. So you're flossing once a day really well, not to just get the food out, but really flossing, and then using the Proxibrush, and you're literally going in between the teeth and you're pushing the tissue down at the same time. So if you picture, you have that pocket, and now you're taking a brush and you're kind of pushing it down, it decreases that pocket. So it's less areas for bacteria to hide. Everything is about creating an environment that bacteria can't flourish, if that makes sense, or the biofilm. Okay. Proxibrush do's and don'ts. Don't use it, don't push it where it doesn't want to go. There's a lot of different sizes. You want to use the biggest size that will fit into a space. But if you've got a small one and you're trying to get it in and it's not going, please don't force it. That's going to cause trauma to your gums, and you won't like that at all. So don't push it where it doesn't want to go. As I mentioned, use the biggest size that you can use for that area. A lot of people have different size brushes for different areas. So in my practice, where I've had a lot of surgical correction, they might have a space in the back that's really big, and then in the front, it's not so big. So they have two different sizes. Push the tissue down. So when you're doing it on the lower teeth, you're pushing the tissue down while you're going in between, and on the top, you're pushing the tissue up. And then common brands are gum or tepe. Tepe, there are some that are huge, and I have patients that use them, because you might have a space where a crown is or an implant is, and you just need to be able to clean that site. So you picture there's a triangle. You want to get that brush into that whole triangle. And then if there's bridge work, you want to use what's called a super floss. That's the easiest way to get underneath the restorations. But we want pristine, and we're very picky about it in our practice. So when I walk in and my hygienist says they look great, I know that they look great because we're very picky. We are very clear to say, this is where you have pockets. This is where you need to improve on your hygiene. This is where you need to clean back here, and this is how you're going to do it. And those are the things I want you to look for in a hygienist, because not everybody's created equal. You don't want them to just clean your teeth and just send you off. You want them to give you that constructive criticism and to say, you know what, have you tried this back here? Or did you even notice that you're not getting back here? And you might not even realize that you're not cleaning it well back there. That's where your hygienist comes in. Okay. And then at a different time of day, and again, you don't have to do this if you don't have gum disease. I don't have gum disease, but I've added this to the mix just because I'm getting older. And I like how it feels. So I use a water pick. So if you're using your floss and your proxa brush in the morning, then at night I use my water pick. And in the water pick, you want to use kind of lukewarm water if you can. If you can use filtered water, it's even better. You can add hydrogen peroxide a couple times a week, only if you don't have silver fillings. You can add sea salt and saline, but you just have to make sure to clean your unit after. You can also use biocedin or dental sedin drops, which I do often as well. And it just really feels good. It's actually pretty amazing what comes out after you eat using a water pick. So this is just, the basics of what I recommend. And just doing these few things shouldn't take you, 20 minutes 3 times a day. It should take you 5 minutes tops. And if you do those things, I mean, you're head and shoulders above most, I would say. And then I added some recipes that you could use. Dental sedin is just the rinse. You can use dental sedin, 2 pumps in about 200 mils of water. You can also use the biocedin drops. I do both, not together, but I don't do anything every day. I kind of pulse things out. That's just me. You can use hydrogen peroxide. Again, I know Dr. Lewis doesn't love it, every day. I don't either. Just a couple times a week. We don't want to go completely scorched earth and just kill everything. So here it's talking about, you have to be careful about food grade. You have to make sure it's really, really, really diluted. And then you're talking about 1/8 teaspoon of salt. You can add, unprocessed salt, which is our pink or gray salts. You can also add 1/8 teaspoon of sodium bicarb or potassium bicarb. And then here's just saying 3 tablespoons of 3% hydrogen peroxide and 1.5 cups water. You don't have to use these recipes verbatim. I put some water in and I put a little bit of hydrogen peroxide if that's what I'm doing. So, but these are just examples of recipes that you can use in your water pick. And the last component of oral hygiene is rinsing. I don't recommend any of the chemical mouth rinses just because of the ingredients, and a lot of them are very acidic. So colloidal silver is fantastic. I'm actually hoping to be starting some studies with that company, Argentine Silver. I should know their names.
Argentine 23. Yep.
Yes. Yes. So they don't particularly have a product that's a mouth rinse per se, but we're getting into that. So because I think colloidal silver just has fantastic properties, doesn't taste like anything. So I think it would just be easier for patients to be compliant on. Plus it helps with fungus, candida, things like that. Most of my clients don't know what colloidal silver is, but I know you all do. Coconut oil, fantastic. Again, that works against fungus as well. Just easy. Most people have that at their house. You can do a hydrogen peroxide solution a couple times a week. Biocedin. You can just do salt water, good old salt water. That's what I've been doing after surgery for years. I don't do Listerine. I don't do any of that. I just say, put some salt in some water and it works fantastic. And it doesn't cost a lot of money. In terms of gum disease, again, this is where my education is constantly improving, along with, my surgical techniques. This is the most fascinating element of how it affects gum disease. And I know that all of your clients are very familiar with all of these things. These are the things that prompted me to get certified in functional medicine. And everything that I learn, I'm able to teach, my patients. So the confounding factors with gum disease, and again, if you don't have gum disease, then this might not be relevant, but I feel like all of these are relevant to any disease you're talking about. Your diet, everything, food allergies, leaky gut, your vitamins, your vitamin and mineral intake, and if they're being absorbed in the body, your weight, your smoking habits, your levels of oral hygiene. Doesn't matter if you have the best diet. Well, I shouldn't say that. Some people don't ever brush their teeth and they don't have gum disease. So those are the immunologic factors and the host factors that some people have and others do not. So that I didn't even discuss. Some people never brush their teeth And I have a case actually later, I'll show you. Some people never brush their teeth, and then their spouse is constantly brushing their teeth. This one has gum disease. The guy that never brushes his teeth does not have gum disease. And it's all about a susceptible host. And again, that's the case with most disease. So we can have a pathogen, but when does it become pathogenic? It's when we have a susceptible host. I think that comes into when we're talking about germ theory. It's not the bacteria, it's the terrain, right? So genetics, that's a big thing. I have a lot of people that say, well, my parents had this, so I'm going to have it. And I try not to get into a huge conversation about that, but epigenetics shows us that's not the case, that what we do in our environment absolutely affects our genetics. So even if you had a parent that lost all their teeth, well, that doesn't mean that you're going to lose all your teeth. Pharmaceuticals, huge. So, I mean, that's again, a whole other webinar. Exercise, stress, sleep hygiene. If you're not sleeping, you're not healing. And EMF radiation is another one, motivation and timeliness of treatment, or compliance. And then compounded infections. I see a lot of patients that have multiple infections. They have viral, fungal, they've got, parasitic, they've got everything going on. And unfortunately, gum disease is a little bit of all of those things. And Dr. Lewis, I meant to say, if you can contact Oral DNA and see if they can start looking at Entamoeba gingivalis, that would be great, because there's large parasitic component to these things, and right now they're not testing for that. So at this point, if there's no indication for any periodontal therapy, then you've got to kind of think about other sources of infection other than the gum line. So the oral DNA test, they talk about that it's really just about what's underneath the gum line. But my issue is, and what I'm learning as time goes on, is where is it coming from? Like myself, I have my case. I'll show it to you. I don't have gum disease. So where is it coming from? Where's that bacteria? I don't have any root canals. I don't really have any fillings. I have one veneer, and I do have areas where I've had my wisdom teeth removed. And so those could be cavitation sites, which I know I have a cavitation site. But one of the biggest things that they mention is it's transmissible. So if your spouse has gum disease and somebody that you're kissing has gum disease, it's transmissible. Your dog, they actually have studies on how dogs with gum disease that kiss you, they can transmit those bacteria. So just be mindful of that. And then think about, this is the conversation I had with Oral DNA, is other sites. So when you're talking about, where is this bacteria coming from? If I don't have root canals, might be a cavitation. I'll talk about that a little bit. Could it be coming from the throat, the nose? It's all connected. So I do have a few recommendations for that. We've all talked about, I'm sure with Dr. Mercola and Dr. Lewis, nebulization with hydrogen peroxide. Everything starts here in the nose when you're talking about, viral disease. So anytime you're cleaning your nose out, that's a fantastic thing. I'm not going to get too much into this. Coconut oil pulling, again, takes bacteria from our sinuses. Throat sprays such as colloidal silver or biocidin sprays. So if you're feeling kind of, I like thieves spray as well for that purpose. So gargling with salt water, all those things, biocidin throat spray, I think that's redundant. But nasal hygiene, something that dentists never talk about, but again, really important, because if you're cleaning here, it's going to, you're going to have less that's pooling into your mouth. So some examples are neti pot. Again, you can use some biocidin drops in there, 5 to 10 drops of biocidin liquid. There's an LSF form. It's of course more expensive. With a neti pot or anything you're putting in your nose, just make sure it's sterile water or distilled water, never tap water. There's stories of people passing because of organisms in the water. So you can use several times daily. One product I love and I use at home is called Alkalol. It's essential oils, and I get that on Amazon. It just feels good. I hate that neti pot, but it I can tolerate that. It feels good when I breathe it in because it has those essential oils. A saline nasal bottle, I think you can read that. It's the same principle, is that you're using something like a biocidin that's got, they're herbal, it's herbal, and you're putting it up your nose. And then you can actually put that also in a nebulizer. And here you can say biocidin can also be applied topically in the nose several times a day. Again, there's so many other things that you can use, but these are just examples of nasal hygiene. So once these initial steps have been taken, again, depending on your, what types of restorations you have in your mouth, if you have gum disease or not, what your DNA test says, they recommend retesting after 12 weeks. So if you say, hey, I don't have gum disease, I'm going to try this new protocol, you absolutely can retest. But sometimes, unfortunately, you're chasing a bacterium that's not going away. And that's what's happening to me right now. So I just want you to look at it as objective information and not drive yourself crazy if you can't get a specific bacterium down. I think based on what I've seen, I think there's bacteria coming from root canals, but it hasn't been studied. I think there's absolutely bacteria coming from cavitations that hasn't been studied. So when I have my cavitation removed, which I know I have, I'm going to take my test and then get tested after and see if I have a decrease. So, again, in my practice, there's not a ton of people that get their cavitations removed. There's just that's a whole, that's another conversation. But I do think there's a component of that because, and especially in your clients, there's not a ton of bacteria. There's bacteria, but they usually don't have gum disease. So where's that bacteria coming from? And I haven't found the perfect medicine. That makes sense. Not medicine, but the perfect rinse or the magic bullet that's going to work on everybody to get those bacteria down. That's where I'm hoping that the colloidal silver is going to come in, and maybe the copper. So just, again, if you have root canals, a whole other conversation. Most dentists are not going to tell you to remove those. Getting a CBCT scan or a 3D scan is an important aspect of seeing if there are any hidden infections. Technically, they're all infected. But on a 3D scan, you can see lesions that you might not see on a two-dimensional scan. So that's where I would start first if I had root canals. And I always ask for a radiology report with that. I always want a board-certified specialist looking at this scan because they look at other parts of your anatomy that are in the space. So their carotids. Half of my patients find calcifications in their carotids just from our dental CBCT scans. Okay. So again, another topic altogether, not to freak anybody out. It's all information. Okay. So a couple clinical cases and then we'll wrap this up. Sorry, I don't know what time it is. Are we good on time? You're okay?
It's
okay.
fascinating.
So, you think so?
Oh yeah.
So here is healthy mouth, right? So this, I don't need to say anything more. Nice pink, beautiful gums. There's no tartar buildup. There's no inflammation. Okay. And then we have something like this. So this person's obese, which we can see on examination. You can't see in this picture. They have diabetes. Their hemoglobin A1C is 11, and they're hypertensive at 180 over 110. So an untrained eye, you can still see there's problems here, right? We can see these gums are not healthy. We can see the tartar buildup. We can see how, because of the gum movement and the movement of the teeth, that the teeth are moving, okay? And then that affects their bite. And that's pathologic migration, which is not a great sign. And I'd like to say that this is rare, but it's not. And I wish our medical colleagues, the ones that are seeing patients, would take a look at somebody's mouth because you know there's a problem here. Okay. This is an example of their x-rays. This is not a full mouth series, but this is kind of the front 7 x-rays of a full mouth series. And so the red is showing where the bone levels are, okay? And the blue is showing where the bone levels should be. So this is why it's important to get these x-rays, because a lot of times you go to the dentist and they take the x-rays in the back and it only shows the crowns of the teeth. Well, I need to see at the ends of these roots to see if I can see any infections, and I need to see exactly where the bone levels are. So I mean, you can see on all of these, the red is where the bone is, and the blue is where it's supposed to be. So these people have lost vertical height here. You can see vertical, and then there's vertical here. They're losing in between the teeth. So this is pretty severe. Okay. I'm not going to go through this again. This is beating a dead horse. We went through that already, but you can just kind of see the tartar buildup causes the ulceration. And then this is where everything enters the bloodstream. Okay. And, again, it's the inflammatory response causing tissue destruction. And then you end up with bone loss in your mouth. Okay. So this is picture of plaque. Plaque can be green, it can be black, it can be yellow, it can be white. There's a lot of different signs. You can see inflammation, and it's kind of swollen. And for some people, this is just gingivitis, and you don't know until you take a probe and you start measuring. So if it's gingivitis, everything's 3 millimeters. Some of them will be 4. There hasn't been any bone destruction yet. You clean this off, it's going to get back to normal. It's reversible. If we start getting into deeper measurements, starting with bone loss, then we're talking about gum disease. Okay. Oh, I guess we were going to talk about that. So we're talking about bacterial plaque leads to gingivitis, leads to periodontitis. Everything is about a susceptible host. Okay. So this is an example of the case I was talking about. Here's a guy that never brushes his teeth. I know you can't tell here, got a nice cleaning. And here's his wife. He does not have gum disease. His wife cleans all the time, is really good about coming in for cleanings all the time. And she's got gum disease. Why is that? And it's all about the susceptible host. We all are different in terms of what we can, I don't want to say accept, that's not the right word. What's the word I'm looking for? What we can tolerate, what we can handle, what our bodies can handle. Okay. This is an example if you're looking at an isolated, like a localized measurement. And this is when you see me and I try to grow that back. This can be due to your bite. This can be due to a fracture. This can be due to a piece of food got stuck in there. This doesn't necessarily mean you have gum disease everywhere, but guess what? You take an oral DNA test and you have something like this, it's going to show up because bacteria hangs out in that pocket. Okay. That's just showing normal bone levels. Here's another one where everything looks good, and then you've got one isolated site. That's still gonna show up. Thermography will show this as well. I'm pretty amazed at how specific thermography is. I have crowding in my mouth, and it'll show right. It's amazing. But with something like this, we've got bone loss. Okay, so until you might look and go, it's just gingivitis, but you don't know until you take a probe and you take an x-ray. One note on recession. A lot of people say, well, I have recession. Recession isn't necessarily gum disease. Now, gum disease can cause recession, but you can have recession defects like this, and it can just be due to tooth position. It could be from brushing your teeth too hard or just having thin tissue to begin with. So, and it also can be from your bite. So don't just think that because you have recession that you have gum disease, because it's not the same thing. Okay. So first case, I have 2 cases and then we're done. This case, he is 32 years old. Now, this is a pano. This is a panoramic x-ray. And a lot of offices will only take this one and then just take a couple x-rays in the back. The problem with this it's great to see everything, right? You can see your sinuses, you can see, usually you can see the condyles back here of your joint. You can see where the wisdom teeth are, and you can kind of see there's some bone loss here, but you don't see the detail. So it's really always important to get what's called the full mouth series, okay? This is the 18 little x-rays that I was talking about. And we can see on the end of every single root, and we can see the bone levels. And I'm not sure how well you guys can see, but very severe bone loss, okay? Bone is really, really far up. And you're looking at somebody like this, and my first conversation is, would you like to try to save your teeth? It's not uncommon in this situation to say, would you like to convert to something that is more long-term, like implants, okay? We took out these 2 teeth because there's no bone anymore around those teeth. And just a note, your dentist always takes bite wings. So if they're only taking these bite wings, they always take horizontal bite wings. You can see some information. You can see some bone loss. You can see some tartar here. But these vertical bite wings, you can see so much more. So the type of x-rays you get matters as well, okay? That's why I like these, because I can see every single tooth in the mouth. And if you have restorations, guess what? It'll show if you've got infection on the end of a root. And that's a big deal. You won't see that if you're just getting these x-rays all the time, okay? And those infections on the ends of the root, which is kind of hard to see here. Here's an example here, but it can be from root canal tooth. Those are chronic infections. And guess what? That bacteria is constantly going into the bone. So hard to see these pictures. My intraoral camera is not the best, but very bright red, pink, or bright red tissue. It's not pink. It bleeds when I measure, and a lot of some tartar buildup. And this is an example of what's called charting. So remember when I was saying you want to take 6 measurements around each tooth. So here's 3 around this tooth and 3 on the back. And we're going all the way across this way. We're going all the way across this way. And I just want you to kind of take a look. You don't need to read all the numbers, but all of this is bleeding, meaning when I take measurements. And then all of these numbers that are in red are over 3 millimeters. That's the way my system shows it. So when we look at this, we go, there's a ton of measurements that are over 3 millimeters. There's a lot of really, really deep measurements. And this is something we do at every single appointment. So some offices only do it once a year on people. This is just something I feel is very important. But again, depending on what dental practice you go to, they may or may not do this. Obviously, if you don't have gum disease, this isn't as important. I just had my teeth cleaned yesterday and I'm like, don't worry about it. She checked a few and I'm like, don't worry about it. But somebody with gum disease, we constantly have to monitor this because it doesn't stay stable all the time, okay? So our treatment plan was the exam, and we did an oral DNA test. This is a gentleman that I absolutely recommended the oral DNA test, mainly because of the severity and his age, really, really young. We decided to do scaling and root planing. That's always the first line of treatment. And we did it in 2 sections because of his insurance, would only pay that way. We reevaluated about a month later or so. And then he's on a 3-month maintenance cycle because bacteria repopulates about 3 months. We did a retest about a year later. And we've recently, I say recently, it's been 6 months now, did surgical correction and regeneration in the upper left. But I want to show you, whether or not you can see here, this was at his reevaluation appointment after the deep cleaning. So what you can see automatically, and we show them the difference, is way less red. So the pockets have all, come down. We're going in the right direction, right? We have a lot less bleeding. He's cleaning really well at home. And this was the results of his first oral DNA test. So you can see a lot of bacteria and a lot over that threshold. And then this is his retest. So yes, there's still some bacteria there, but 49% reduction, I'll take it. Clinically, he looks way better. I thought we were going to have to remove most of his teeth at this point, and a lot of his teeth have tightened up, and it's a lot of it just working on diet, vitamin D status, coming in for cleanings and being compliant. There's a lot of factors that play into that. But I mean, this is where this oral DNA shines for me, is when you have a patient that's so severe and you can see it and it all correlates with what we're seeing clinically. And then, wow. So most of it, I want to say, most of Dr. Lewis's clients are here. So, and that's kind of where I am too. So yes, there's still bacteria, but we need to find out where it's coming from in those people that don't have gum disease. This is me. Oh no, that's not me. Hold on, I have 3 cases. This is a 67-year-old female. You can see a lot of red. Again, a lot of probing depths and a lot of bleeding. You can see she's got a dental implant. You can see she's got root canals. She's got a lot going on in here. Okay, all these crowns. You get bacteria underneath. But when you're looking at her bone levels don't look bad. She's got a little bone loss, but compared to the last gentleman, she looks pretty darn good. She had a lesion that we had to remove. So that's something that I do. I remove that and put a soft tissue graft here, and we biopsy that. That's kind of separate than cleaning her gums. Okay. So our treatment plan, oral DNA test, the deep cleaning again, the reevaluation, the oral DNA retest, and then she's on a 3-month maintenance. So clinically, she's improved greatly. Again, you see there's a lot less red. When you look at her oral DNA test, there's actually a 5% increase. So a conundrum with my hygienist and I, we look at that and go, okay, so the body's not healed. The bacteria is increasing, but the body's healing a little bit. Where's the bacteria coming from? So that to me is where I look at, but she's got root canals. There's things like that I feel like that's where the bacteria is coming from. Also, she's not regularly cleaning her nose, ear, nose, and throat. So this is objective information. And then last case is me. No history of gum disease. I've never had gum disease. I have occasional bleeding. I know that's terrible, but I have a couple crowded teeth, so I'm not infallible, but I don't have root canals or restorations. And I'm kind of on a mission, because here I don't have a lot of bacteria, I don't have anything over the threshold, but I still have bacteria. And look, in the second one, after I started a protocol, I have higher FN, which is Fusobacterium nucleatum. So it's a work in progress, and I'm working on it. Even if you're using the protocols that I'm giving you, it may or may not work on you. And so if you want to go down a rabbit hole, you can absolutely get retested all the time. I'm doing it just for educational purposes. What I want to do is a study with Argentin and colloidal silver, and then another one is get my cavitation fixed and then retest. So yeah, it's great objective information, especially if you're not sure if you've ever been diagnosed with gum disease or anybody's ever checked. But it absolutely has a role in treating gum disease. So to summarize, oral DNA test doesn't take the place of a periodontal evaluation, but especially if you haven't been in the dentist in a long time, you haven't been treated, it could really show the dentist, what's going on. And, especially in probably a regular population as well, it is slightly diagnostic, because if you've got all of this bacteria, then you go to the dentist and you go, hello, you need to check this. It's information, it's useful information. Find a dentist and a hygienist. There's 2 different things. Most of my patients see my hygienist more than me now. So you want to make sure that you find a hygienist within a practice that you really, really like. And that's okay with you asking questions. And that is okay with them showing you those pockets, like I was saying, and show you your charting. And hey, this is where you're having issues. This is what I want you to work on. Depending on your maintenance interval and your disease level, make sure they're taking your measurements at every visit. They can change. Even if you're stable, the next time you might be unstable. Stress, COVID, all these things that are constantly, all the toxins, it can change. So you don't want to just assume because you don't have it now that you won't have it in the future. And the one thing I want to say is just do the best you can. If you are flossing and using your boxer brush and using your water pick and cleaning your ear, nose, and throat and rinsing and all of those things, and you're eating a healthy diet and you're doing those things and you don't feel like you want to get a root canal removed, it's okay. You do the best that you can. That's, because I know we all want to be as healthy as we can be. I just want you to look at it again as it's just objective information. And all you can do is the best you can. I mean, I can help by, if you have specific situations that you want to discuss. There's been situations where they have a few root canals and they'll say, which one would you remove first and why, et cetera. There's a lot of different things that we can talk about. Obviously, I'm not there looking in your mouth, so you have to go to your dentist as well. But maybe you have questions about what to ask, and I can help you with that. And again, you would upload any radiographs and photos and reports. And for viability reasons, I can't read CBCT scans or the 3D scans. Every single program's different as well, so it just doesn't work, and I just can't do it for liability reasons. But I would always recommend a radiology report. I'd be happy to look at that report with you as well. So one of my favorite little memes, how deep is the mud, depends on who you ask. We all go through the same stuff differently. So I want to thank Dr. Lewis again for inviting me to work with him and to come on tonight. I hope I didn't absolutely bore everybody to death. So
Dr. Berube, that exceeded expectations that I set out at a very high level. We have tons of questions, so all I can tell you is we're not going to be able to do those tonight. Sorry, folks. But
no.
Will you come back and we can just do a Q&A and I'll save all these questions?
Absolutely.
And I want to ask you one question.
Yes, sir.
So someone is getting up there in age and they have a root canal.
Mm-hmm.
And it's sort of in the back.
Mm-hmm.
If they pull that tooth, do they really have to worry about the teeth migrating and the number of years we have left when we're like 75 years old, or can they just pull the tooth?
Maybe.
What's that? We didn't quite hear you.
Maybe. The reason why I say that depends which back tooth. So if it's the second, assuming you have your third molars removed and you have your second molar back here, and you need to remove a second molar, that's one of those teeth that I tell patients is optional to replace. However, if you're getting a tooth removed that's in between two teeth, so say your first molar where it's in between your premolar and your molar, what happens is if you don't replace it, number one, you'll lose the bone. Number two, your top tooth will drift down, which will happen in the back too, but your teeth will start to drift in. Kind of think about it as a fence post. You take out a fence post and everything drops. It's the same thing with teeth. So the amount of time that it takes for it to drift, I don't know. Sometimes it's quick, and for some people it never happens. It depends on your bite. If it's a tooth on the top with the sinus, that sinus will drift down. So, if it's in between a tooth and you take out that tooth and you don't replace it, and then you need to take out the back tooth, now you have no molars, and now your sinus has drifted into the space. So I don't know if that made sense at all.
Oh my God. Very enlightening.
So maybe. It just depends on which tooth. It depends on what it's biting against. And it depends on how many other teeth you have. Because every time you take out a tooth and don't replace it, then you're putting more pressure on the rest of your teeth. So again, it's a very specific thing, and it depends on the person and kind of what they're looking for. But I have many patients that are only in first molar and forward. I have a few that are premolar and forward, and they're fine.
Well, I can tell you, if I was 80 years old, and of course, periodontal disease is going to increase with age, I would just yank that thar tooth. And, Dr. Gelb, an Uber optometrist, did a documentary called Open Your Eyes about, eye health. And he did cataract surgery on 3 centenarians in Costa Rica. And I'm looking at them, and they have very few teeth. And I'm saying, why are they still alive? And the answer is because they pulled the bad teeth. But they've done nothing to replace them, and they're 100 years old, and the older guy, 120 pounds soaking wet, is out chopping wood. He's 101 years old.
Yeah. It depends on the tooth.
Yeah, I understand.
It's one of those things we always say, you need a tooth removed. Personally, in my office, we do a lot of bone grafting or socket preservation because you don't know if you're going to miss the tooth until it's gone. And for some, it might not bother them. I have patients that don't replace them. They remove it and they say, Doc, I'm good. I don't need to replace it. I go, great. You've got nice, good jawbone now. It's fantastic. And then I have many that go, yep, I missed that tooth. I want that tooth back. That's you just don't know.
Decent validation that it's not necessarily an absolute. And I'd like to invite Dr. Harshfield to come on for a second, because you say you can't read certain radiological reports.
Mm-hmm. But the scan.
But we have a functional interventional radiologist on our team. So I'd like to introduce Dr. Patty Berube to Dr. David Harshfield. And are you there, David?
Nice to meet you.
Patty, maybe you can get rid of your share screen, and so we can see full scale here.
Okay, how do I do that?
It's not mandatory. If you can't figure it out, no big deal. But I think just click on the share, and you should be able to see some green or black little oval thing that says share. There you go.
I got
it. So David, do you have any ability to read those scans and meet Dr. Berube?
Nice to meet you. And I used to do a lot. Great presentation. I used to do a lot of sinus CT and so forth. The upright CT is really good. I like scanning patients in an upright position for a number of reasons, but you can see so much information in addition to the dental stuff, which you're going to read way far better than me. I can look at a lot of things that are going on the sinus, the maxillary sinus, deviation of a septum, turbinate, hyperaeration, stuff like that. Also, we're looking at some really interesting things. You talked about vascular calcification, extremely important. But these long styloid processes can compress the jugular vein.
Yes.
So, there's a whole bunch of information in the field of view. I really enjoy reading them with you guys. I can't read the dental work, but it's kind of like when I read a coronary CT with a cardiologist. He'll read the vascular stuff in the heart. I look at the lung, spine, and everything else in the field of view. It's really powerful.
Excellent.
And that's where I tell people I need somebody like Dr. Hirschfeld to look, because I wasn't trained. And when I see these radiology reports come back, and they're, like I said, I have half of my patients that have calcifications in their carotids. So it's just too important. That's why I don't want to miss anything. I can look at a scan to look at bone volume and things like that. But yeah, what I was saying was there's just so many different types, meaning I'm trained on one specific type of scan, and then there's just different machines and different software. So that's it's really hard to monkey with somebody else's software when you're not used to it.
And then just my last comment before we close is, a red blood cell goes to your heart every minute. So it's going through your infected gums, your gingivitis gums every minute. So it will become systemic. And that's why I use the white blood cell counts. And I think the treatments that they have for this that are antibiotic are very short-term, sort of localized, systemic, and it's like you're slapping a hornet's nest and releasing a lot of pathogens. And there's very good studies that show that the risk of a heart attack after a dental procedure is up at the same level for at least a month and then slowly tails off. But the folks out there that are listening that have severe periodontal disease most likely have it lodged in the bone, but also have it systemically. That's why you have joint pain. That's why you have calcification in your other tissue. And you are a candidate for systemic treatment that we do that goes beyond the type of sort of short-term systemic treatment recommended by the oral DNA folks. Just a comment. And that's completely dictated by the oral DNA test and a diagnosis of periodontal disease, elevated white blood cell counts or neutrophil percent, neutrophil to lymphocyte ratio, and of course symptomology. And everybody can get one of those lifeline scans that take a look at the carotid arteries and any other advice that Dr. Harshfield has on things to measure where you are on the vascular and endothelial vessel dysfunction continuum, which is extraordinarily important. But this is the faucet that's running, okay? And we need to shut that faucet off. And then when we look at the entire terrain that Dr. Berube talked about, we also have to clear the drain out. And it's not just here. It's got to be systemic in so many cases.
100%. Absolutely.
Yeah. So fantastic. You tell me when you can come back. And, you mentioned 20 different seminars, but I think what would be pretty good, really good though, is just a lot of people have specific questions and this group learns from each other. I mean, I'll save the chat and send it to you so you can see the
absolutely. Yeah. I'd love to come back if you want me to.
But we definitely would like sort of a Q&A session. And I think we could fill the hour with a Q&A. Wouldn't, you don't have to nod out there, but I think you all would agree. And my parting comment is I am coming to Dallas for planing and debridement.
Okay.
It's been way too long, and I'm not going locally here in Tennessee. I don't need to be treated with moonshine, although I'll accept that post-treatment.
Okay. Well, just let me know because my hygienist is booked out for months. It's upsetting to people, but I could always do it for you too. So
I can wait. I can wait. It's been a long time. Thank you, Dr.
Sounds great. Thanks, everybody.
And thank
Take
you.
care.
Bye.
Bye-bye.
Good week.
Bye-bye.